an Italian brand, so made in Italy technology. I wish to thank this conference and the organizers for allowing me to show you our technique. So a custom transepithelial technique plus CXL. So the so-called CXL plus techniques are numerous and varied. My technique has been named CCR, so central corneal regularization, made in Italy, custom platform, iris, and tomograph with dual Schönflug camera. And then we have a minimum ablation, corneal ablation, and this transepithelial ablation is performed by means of a high-frequency laser, 1 kilohertz. So the aim of the surgery, in other words, is to bring a corneal region of a predetermined central diameter to a spherical surface in order to reduce a high-order aberration. So this is done in a no-touch way, so plus CXL in order to increase the strength and resistance of the cornea to deformation. So we are talking about 9 millimeters, 10 minutes, 9 milliwatts riboflavin. So the CXL has released us of the need to use excimer laser in our surgery. So a few years ago we started going for it, and here you may see the post-op period. So it's 3, 6, and 5 years, and during the years we have standardized progressively our technique. That's a very short video summarizing the technique. This is the UV emitter. So it's 9 milliwatts, as I said. First of all, the laser ablation is performed. This is the ablation of the patient. So under excimer laser, that is a high-frequency laser. So we perform in about 30 seconds transepithelial ablation, about 30 seconds, and it also desepithelize up to 9 millimeters. So pilocarpine, riboflavin, about 15 minutes. So the UV emitter that is already assembled on the laser on the eye of the patient, and the CXL is performed. Okay, inclusion criteria for the time being, they are very strict. So primary ectasia, so keratoconus pellucida, good or quite good or sufficient pachymetry, low BCVA, and intolerability to eyeglasses. And this is a patient. These are the refractive parameters. So 2 images of the patient. At the center, you may see the high repeatability up to 3 microns. This data is imported into the ablation software. So on the left-hand side, we have the cornea fitting with a sphere, and on the right-hand side, an aconic fitting, highlighting the high-order aberrations of the cornea. So the ablation desired is shown on the right-hand side. This sort of ablation is in line with the depth of the mean depth of our case series, and here you see the differential maps on the top, the theoretical, at the bottom the theoretical ablation, and on the top we see the actual ablation. So you may see here there is a better regularization of the central portion of the cornea. So in white you see the curvature changes, and the number of colors on the left are higher compared to the right image having fewer colors. And this can also be seen here with the tangential algorithm map. And here on the right hand side we have a nearly completely green area, so it's more accurate. So here you may see 2, 3, 4 millimeters high order aberrations on the anterior cornea as well on the whole cornea, and these are pre-op values compared to post-op values, especially at the center. A sharp reduction of these aberrations may be observed. And we've also used a placid disc topographer and here you may see that the OPD coma and aberration from its pre-op on the left and the post-op on the right. So this, of course, reflected in the follow-up after 1 year, so an improvement in the visual acuity, both corrected and uncorrected. So this is a standardized technique that is also used in other countries, and you see the number of cases that have been operated in the various countries. And here I summarized the case series of the 15 patients who so far have completed the follow-up 6 months to 2 years. That's the data for uncorrected visual acuity. That's a decimal scale in blue pre-op, in red post-op, so you may see the improvement of the visual acuity. The uncorrected visual acuity has remained stable in time, and you may also see the cylinder. So here we measure the total and anterior high order aberrations, top and down, and so on the top and in blue the pre-op, and in red the post-op data. This is the mean values, so 30 microns on average up to 7.3. And the aberration is the same for the 5 millimeters. But the OPD and coma calculations with the topographer with placid rings or discs, so you may see the outcome in terms of the coma. So, as a whole, we succeeded in reducing high-order aberrations, OPD and coma, by more than 60% to 2 millimeters. And the coma aberration, that is the major one, the most important one, when there is a corneal atresia, was reduced by nearly 60%, even measuring at 5 millimeters. So there was a detail in the rehabilitation of these patients, and we have used the fluoromethalone drops or superficial steroid, and that's the corneal opacity, and no patients have lost any lines in terms of corrected visual acuity. We have corrected the high order aberrations, so we have improved the quality of vision by over 60% in all the patients. So for the time being, we may say that this is a safe treatment, but it isn't a refractive treatment. So we do not promise the patients that they won't have to wear glasses or they will be less myopic. It is only aimed at improving the visual acuity in patients who do not tolerate contact lenses or eyeglasses, and with a pachymetry that allows for such a technique. So the selection of patients is key. Of course, in the long term, we are collecting data to check the evolution of these corneas prior to the definitive validation of this technique.